morning, good afternoon, and good evening, everybody. Thanks so much for being here, joining us in a very interesting MOH talk again with the top experts from around the globe. Today, we have a very special events from UK with our clinical advisor from Silvers Group in Britain, Kat Stevens, and also with other top-notch speakers from UK. Uh, in a personal note, I'm really looking forward to this event and to see together how things work differently from country to another. As you know, Medical Online Hub is a platform where we are always looking for exchange between the top experts and the top hot topics discussed at the moment within the venous lymphatic world. So, because at Silverius Group, we're always looking to promote the exchange of the scientific knowledge on a global scale, we also like to have a very specific events where we can understand more how it works in a specific market. So please feel free to send over your questions, your comments. As you can see, we have the chat options or the function of the Q&A where you can also place all your questions. I'm really looking forward for the event. Having said that, I would like to introduce with pleasure my colleagues, the clinical advisor, Kate Stevens from UK. She's expert as a nurse for more than 25 years, doing a lot of things with the patients, especially in the wound care. She has a huge passion, working closely with the different stakeholders to bring the right solution. I'm really proud and honored that I had the opportunity also to work together with her once in UK in the College of Philology, where we have the possibility to also demonstrate our unique and innovative solutions. So, Katie, stage is yours, and I'm looking forward to the discussion.
Thank you so much, Mahmood, and what a wonderful introduction. This is my first time on MOH moderating, so I'm really excited to be here today. And welcome everybody. I just want to apologise first of all if there was any miscommunication. Some of you have been waiting a bit longer to join the talk at this time, so I really do apologise for that. And just so pleased that you're all here to make it with us, either this morning, this afternoon, or this evening, wherever you are in the world. So the topic of conversation today is why early lower limb intervention matters and how we can simplify decision making. We've got some leading experts on the panel today, which I'm really excited to have with us. So I'd just like to welcome Mr. Adam Howard. He's a vascular consultant and general surgeon based at the Colchester Regional Vascular Unit. We have Helen Langthorne with us as well. Helen is a leg ulcer clinical nurse specialist that also works part of the vascular department. We have Susan Knight, who is a tissue viability nurse, consultant and lecturer here within the UK. And of course, myself, Katie Stevens, who's going to be moderating today. So the reason why we wanted to pull today's talk together is because chronic venous insufficiency and leg ulceration have a significant impact on quality of life of the patients that we're seeing. And the reason why I've chosen to be a nurse in this area is because we can really help these patients. However, we know globally the cost of chronic venous insufficiency with and without leg ulceration is in the billions of dollars. Statistics tell us from studies that also our patients that we're seeing or not seeing are often not getting a diagnosis. So without an accurate diagnosis of chronic venous disease and the signs and symptoms that they're showing, or the mixed diseases of chronic edema and lymphedema, these patients don't have access to treatment. And it is the same all over the world. It is a global problem. So we wanted to try and talk about what we've done in the UK to try and combat this. So a few years ago, from government level, something called the National Wound Care Strategy was launched. So within the UK, the first line lower limb management is within GP surgeries with the nurses and community nurses, all within the NHS, one majority. What happens with those patients? They may present, and then it's up to the nurse if they do the correct assessment for chronic venous insufficiency and put in an appropriate care plan. Now, from a recent study within the UK, only 16% of patients actually received this. So that's why the National Wound Care Strategy was implemented to change this. What the nurses then need to do is refer these patients into the vascular department for them to be assessed by vascular, again, for further treatment. And if only 16% are being assessed, how many are actually getting to vascular for the correct treatment? So the National Wound Care Strategy we're going to discuss throughout this talk. It's been a magnificent success, and it highlights the early intervention and why it's important. But with early intervention and going through the pathway, it gets more complex with legs. How do we make the correct decisions for the treatment using evidence? So before we go on to Mr. Adam Howard, who's going to discuss with us the burden of lower limb conditions, and from a vascular perspective, I also hope everybody shares as well some little secrets that they can share with the nurses on the ground or anyone that's not so familiar with lower limb care, what they can do to help their patients that they're seeing in front of them, and just really try and simplify the process. But first of all, we just have a poll question. So I wonder if we can just bring the poll up first. And then that should all appear on your screen. If you can answer that, and we'll just have a quick look at the results. Here we go. Okay, so 47% feel that they're not getting a diagnosis of chronic venous insufficiency. Okay, great. And I think that will help us with just discussing now the burden. So, Mr. Adam Howard, it's over to you, please.
Thank you. Can you hear me clearly?
Yeah, perfectly.
Yeah, good. Thank you. So I see lots of patients in the NHS and in private practice for patients that essentially can't get to be seen quick enough. So they then end up paying out for private appointments because they've got chronic leg swelling, which is causing a massive reduction in their quality of life. So essentially, it's a vicious cycle in that they get leg swelling for whatever reason. It may be heart failure, it may be venous insufficiency, it may be some lymphedema, it may be gravitational edema, and then they become less mobile because the legs become heavy. And then once the legs become heavy, as you know, they then start to spend more time in a chair, and then the legs get blistered, and then they can get cellulitis or infected ulcers. The skin gets very macerated and delicate. So they just need to knock their leg, and then within a few weeks they have developed an ulcer. And then the ulcer becomes a real handicap for them because they're embarrassed about having an ulcer on their legs. They can't go out the house without having bandages on. The bandages get very soggy, their socks get very wet, and they have to change their socks about 3 times a day. And then it starts to get red and angry. And this is the sort of early stages of sort of pre-cellulitis, I would call it. And this is a time when they should really be managed aggressively, because otherwise they're going to develop long-term ulcers or cellulitis and sepsis and end up in hospital. And then once they've had cellulitis, then the lymphatics are damaged, and then they're in this vicious cycle of having poor skin, damaged lymphatics, and they're then constantly fighting an uphill battle. So I see lots of patients, I encourage lots of patients to get treatment very early on. And it's really quite simple. Both my parents have had to have treatment from me. who lived next door. And my father had wraps on for 5 years after an episode of sepsis from cellulitis. And my mother had to have stockings with zips on because she couldn't get the stockings on otherwise. And within a few weeks, the legs have returned to normal, but then they need to keep the compression in place. They need to keep the quality of the skin by using the correct moisturizer. So I use a lot of wraps in my practice because we have patients with heart failure or painful edema, and they can't tolerate stockings, and they have to start with something very gentle and just start very gently to get the edema off the legs, and then the legs get less painful, and then you can build up the compression. So that's where I am mainly involved, and then obviously treating ulcers, which involves vascular surgery or injection therapy, antibiotics, etc. So that's what I see a lot of.
So Howard, so I mean, you receive a lot of referrals in from the NHS, and these patients have been left a long time, haven't they? By the time they get to you with these wet leaking legs or ulcers, it's been too long, hasn't it?
Yeah, and they've often been it's been going on for about 3 to 6 months, and I think the district nurses do a fantastic job, but they may not have the same level of vascular expertise as, say, the vascular nurses, specialist nurses that I work with. And I think the district nurses get a little bit stuck with these patients in that if the patients won't wear the stockings or can't wear the stockings, they try different dressings. If you don't manage the edema, I don't think it matters what dressing you use, personally. The legs are just going to get worse. There's no dressing out there that will beat gross edema and breakdown of the skin. They can't perform miracles with these dressings. And so the patients tell a common story of going round and round in circles. A different nurse comes, they put a different dressing on, and essentially what the patients need is to get the legs up and get the edema off the legs and get some compression in place. And I think some of the nurses are quite scared to get compression in place because of the history of heart failure, or the legs are so grossly edematous that if they try to put stockings on, they may damage the skin and make the situation worse. And so they get into this chronic cycle, and we see them at about 3 to 6 months when the situation has become really quite serious, and that's the only way they can get into secondary care.
Yeah, absolutely. And what you're saying, so my background was community nursing when I first started, and I went into it with confidence about compression. However, I speak to nurses now that are frightened of compression. But I think maybe we need to look at it by not having the confidence to apply compression. Maybe we are causing harm by not treating the legs. The benefits of compression outweigh harm, essentially. And like you say, when patients have the leg ulcers and these skin changes, it's a symptom of what is happening inside the leg. And so I completely agree with you. I've been out where, silver dressings have been put on the legs, and there's a real focus about what dressings can go onto the legs. But unless we deal with the underlying cause, which is the chronic venous insufficiency, then those dressings aren't going to work. So completely agree with you about it being the compression, whether that being, wraps or bandages. But we know now that nurses are up against it with time. They have so many patients to see. So we need to be looking at alternative options to get our patients into compression to deal with the cause and not the... Okay. Clearly enough that
just butt in quickly, because while talking about compression, I have a very low threshold for putting compression in place. So everyone's scared of putting compression in patients with heart failure. I've always put compression on patients with heart failure. I just start with a very low compression. I might start with a Sigvaris liner to start, to build and then build up gradually. In patients with diabetes and peripheral neuropathy, I test their heels and I test their feet and I use a monofilament. But if they can feel their toes, then I feel that they are safe to have open toe stockings. I don't like putting stockings on that are closed toe in diabetic patients with some neuropathy because they may not feel it over the knuckles. So I've not had any problems putting compression on patients in diabetes with a little bit of neuropathy. I know there's the National Wound Care Strategy and there's the red flags and the guidance is to start low compression at 20. I completely agree with that. I have patients that have grossly edematous legs after bypass. And as long as they've got a good flowing bypass that we've checked with our various imaging, and ABPI isn't always reliable, so we use toe pressures. But once the vascular surgeons have seen them and we've checked a bypass patient, and a bypass in the legs this is, then we do put light compression on them. And again, it would be open toe. And we have to give them lots of warning about protecting their heels if they've got neuropathy or they've got peripheral vascular disease. So if they've got an ABPI of 0.7 and they've got gross edema, they're very close to an ulcer. So I would put them in light compression. And I'll be very clear with my instructions. And I would be very keen on them getting out there and trying to walk with the compression in place, because I feel that with compression, if they walk, the calf muscle pump will get some of the fluid out the leg. And if they get the legs up in the daytime with compression on, and I recommend an electric recliner chair for the really severe patients that basically have a bad back and they can't get their legs up, or if they do get their legs up, they're going to potentially damage their heels. Then I say, this is a condition for life. It's worth investing in an electric recliner chair that they can get into a comfortable position, and their back is in a good position, so they don't get chronic backache, and they can safely drink a hot drink at home without it tipping on them, and all these other things that can happen. So I think open toe compression, light compression in heart failure patients, in vascular patients, in patients even with skin which is has been treated for cellulitis and the skin is recovered to a certain extent. As long as you moisturize the skin and it's not really frail, then I think get some compression on. I think it's really important because the antibiotics will work a lot better if you get that stagnant fluid out of the leg. Helen Langthorne, who's on the meeting there, we've been working together for about 15 years or so, and we feel the same way. We have a low threshold for using compression, and Helen I'm sure will tell you.
Brilliant. Thank you so much. That was so empowering to hear that from you. I know from nurses will look up to the vascular consultants, and your opinion is everything. So I feel like you would have really empowered some nurses out there to have the courage to make the decision. So thank you so much.